All right, everyone. Let's go ahead and get started. Thank you all for joining us. We have a pretty good turnout today, so I'm pretty excited. This is the second session of the Transnational Interventional Radiology Journal Club. For those of you who are joining us for the first time, this is an open access inter-institutional collaboration. Basically, that means the IR interest groups at various institutions across the country and soon internationally are joining forces to learn the literature on IR. I think it's a really great way for us to, for the few students at each place interested in IR to connect and for us to start building these kind of relationships early. So with that being said, this is us on the prospective randomized study of doxorubicin-eluting bead embolization in the treatment of hepatocellular carcinoma, which are the results of the PRECISION-5 trial. We are hosted today by Michael Novack at Tulane and Adlai Grayson at Howard, who are both excellent and will give you a great talk today. So with that, go ahead, guys.
We're so glad you guys could join on. This is going to be a very cool discussion, and we hope it's very interactive. So if you guys would be willing to turn on or unmute your videos, that could be great and encouraging discussion. And we're so glad to have Dr. Bordlee, Dr. Bruce Bordlee here to assist in the discussion. We also have Dr. Vatican-Cherry, and I think Dr. Caridi at Tulane may be joining as well. So just really fast, I'd like to see if we can get some of the participants, and I believe it's in the same order down the line, to introduce themselves, some of the medical students.
Michael, I'm here.
Yeah, you're here, Dr. Caridi?
Yeah.
Excellent, excellent. So glad to have you. And I'm going to see if I can see if the participants are in the same order here on my list. I believe it's alphabetized, but I just, if we could go down the line and just introduce yourself, say what med school you're at, and say what year you are. I think that'd be really helpful. So it looks like Amanda Wilson, if you're on the line.
Hey, I'm Amanda. I'm a second year at Howard, and I'm the co-president with Adlai at our RIG interest group.
Very cool. Welcome. Andrew Wang. I know you, Andrew, if you're here. Andrew Fugelstedt.
Hey, how are you doing, Michael?
Andrew, you are muted, just letting you know.
Hi.
Hi.
All right, sorry. Do I introduce myself again?
We didn't hear it, but just say what school you're from, say what year.
Yeah, I'm Andrew. I'm a second year at Tulane, and I'm the secretary of the IR interest group.
Very cool. Fugelstedt.
Hi, my name is Andrew Fugelstedt. I'm the vice president of the IR interest group.
And Brandon Golant.
Hi, I'm Brandon. I attend the Chicago Medical School. I am the ex-president of my IR interest group. I'm an M3 now. And I also attended Tulane for undergrad. So I'm happy to be here with Tulane attendings. And I'm also a member of the MSc Research Committee. So I'm also excited to watch this because hopefully I will be doing one later in the year.
Very cool. Dr. Bordlee, would you be willing to introduce yourself as well?
Absolutely. My name is Bruce Bordlee. I'm one of the interventional radiologists at Tulane. Also in charge of the ESIR program, which we just started last year. And also I have with me, who's at my house today, because believe it or not, New Orleans got hit by a Category 2 hurricane last night, and Dr. Creedy's over at my house now because he doesn't have internet at his. So we are both sitting here outside on the porch, excited to moderate this exciting article.
We're so glad to have you guys here. Awesome. Carmen Carlos.
Hi, everyone. I'm a fourth year at Tulane. I too have been displaced, so I'm at a friend's house. And yeah, so I just submitted my ERAS, so we'll see how that goes.
Awesome. Christopher Neely, if you're on the line.
Hey guys, yeah, I'm Chris. I'm a fourth year at Thomas Jefferson University in Philly. I'm actually in Ohio right now, though. I'm the president of the IRIG there. I'm also on the MSc Education Committee. So I think we're hoping to host one of these maybe in December.
Very cool. Daniel Vague.
Hey guys, my name is Daniel Vague. I'm a third year at NYTCOM in New York. Happy to be the IR chair. It's a subcommittee chair right now because we have some weird rules about starting interest groups at our school. So I'm the subcommittee chair, which will hopefully become the interest group next year. Yeah, I'm excited, and hopefully we'll be hosting the next segment of this.
Awesome, very cool. Dr. Vatican Cherry, if you're on the line. If not, that's okay.
Oh, sorry. Yeah. Hey, Joji Vatican here from LA. Glad to join. Thanks, Dr. Bordlee.
Awesome. Very cool. Hani?
Hi, everyone. My name is Hani. I'm a second year medical school in the New York Osteopathic School of Medicine. I'm serving the president of Radiology Club right now, and got drawn into interventional radiology by Daniel Vague. So hopefully we can do something soon.
Awesome. Hannah Claude, I think you're next.
Hi guys, let's see if my video will work. I'm Hannah. I am in between my third and fourth year. I'm taking a year off to pursue an MBA. I'm from the University of Miami, and I'm helping out with being president this year of the IRIG down there.
Awesome. Henry.
Hi everyone. My name is Henry. I'm a third year at NYTCOM. Sorry for the mask. I'm currently on my rotation. I'm also part of the IR subcommittee with Daniel Vague, and I'll be joining him with the next journal club.
Awesome. Dr. Creedy, if you're on the line, if you're nearby. Otherwise, I think we already got. Okay. John.
I'm here, and I'll just ditto what Bruce said. I'm just here to monitor as well.
Cool. We're so happy to have you. John.
Hi, I'm John Huffnagel. I'm from Creighton University. I'm a fourth year there, and I'm one of the co-presidents of our radiology interest group. And I also work on the VIR interest group committee for the MSc.
Awesome. Mitchell Todd, Tulane.
Hi everyone. I'm Mitchell. I'm also a second year at Tulane, and I'm currently the research coordinator with our IRIG.
Awesome. Thank you, Mitchell. Rajat.
Hi, my name is Raj. I'm a first year medical student at NYTCOM, and I'm part of the IRIG and just help out for whatever IRIG wants at NICOM.
Cool. Welcome. Yasmin.
Hello, I'm a fourth year at Howard University, and I'm the social media coordinator for our radiology interest group.
Is there anyone that I'm missing on the lines?
Me? No.
Perfect segue. Adlai is going to lead the first part of this discussion, a background into TACE and liver malignancy and the workup. So without further ado, Adlai, we'd love to have you take us on a whirlwind tour of TACE and hepatocellular and liver malignancy.
Yes. Thank you, Michael. Thank you, Austin. Thank you, everyone, for coming. Hi, my name is Adlai. I'm a fourth year at Howard, and I'm co-president with Amanda and helping lead with Yasmin, our radiology interest group at Howard. So I'm going to jump in with talking about epidemiology, giving you the layout of why we care. Where is this cancer? So cancer of the liver and intrahepatic bile ducts is the sixth most frequently diagnosed cancer worldwide, with approximately 841,000 new cases reported in 2018. Additionally, primary liver cancer is the fourth leading cause of cancer-related mortality worldwide, with over 780,000 deaths in 2018. So With that 5-year survival of being 18%, we see it's the second most lethal cancer following pancreatic cancer. And when we think about the geographic distribution, next slide, we can see that there's a worldwide incidence of HCC, and it's varying with what some say would say a hepatitis virus, like hepatitis C here that you can see, and hepatitis B. You can click on the next slide. Right, and we see that there was a prevalence in China and Africa, but overall, they say that there is just a higher percentage of people in Asia that have hepatitis, hepatocellular carcinoma. We also see that there is a trend for men or males to be more affected with this than females. We see that Asian Pacific Islanders in general have higher incidence than other groups of identity. And one of the other big things was the year of birth as a big risk factor. People born 1945 to 1965 seem to have a higher predilection for having hepatitis C infection, and with that, development of hepatocellular carcinoma. Now, just one question. What do people think would be risk factors? Anybody can say anything. What would be big risk factors for developing hepatocellular carcinoma?
Alcohol use, maybe, and definitely hepatitis.
Oh, okay. Anybody else? Anything else?
I was going to jump straight to cirrhosis and just blow that. So.
I was going to throw out aspergillus.
Okay. Alpha toxin. Yes.
Non-alcoholic fatty liver disease.
Thank you. That's a big one that's popping up. Awesome. And just one other, if anyone. What was that?
IV drug use.
IV drug use. Why? Why?
So we're thinking of like viral transmission through.
Oh my gosh! Right? Yeah, those IV drugs. Let's go to the next slide. Right. So you guys pretty much said a whole bunch of them, and along with that, they have the minor genetic ones like Wilson's disease and hereditary hematocrosis, along with some autoimmune diseases that may lead to autoimmune hepatitis. You can go on to the next. Oh, and one thing, yeah. So what are some symptoms that people think of when they think of hepatocellular carcinoma? It's hard because often there aren't any symptoms early on, but later on it can develop into abdominal pain, swelling, a mass, you can have fatigue, the general B symptoms, weight loss, ascites, and people will typically diagnose them with a CT or MRI to look for characteristic findings that we all studied for step 2. I love it. So you can also find tumor markers such as alpha beta protein. And we'll talk about some of those labs that you will have to draw later on. We can go on to the next slide. So yeah, here, I just wanted to give you all an idea of an algorithm. There are several algorithms out there, but this algorithm is just one of them that people use in order to assess for whether we should, how we should treat hepatocellular carcinoma. People look at the tumor size, the location, the number of tumors, if it's gone outside of the liver, and they also look for liver function. So if we take a little short, you can see that people with Child-Pugh A and no cirrhosis and potentially resectable would be optimized on medical therapy. Could you click the next slide? And here's just a little picture of sorafenib, and the next one. Great, and there's some immunotherapy that other people are trying. And after that, you would probably do some portal vein embolization in order to grow up any remnant liver that could be helpful after resection. So if you're resectable, you're good, just go into surgery. You can click the next slide, or you can get a transplant. Now, if you have Child-Pugh B or C or unresectable, hopefully if your liver transplant, if you fall under the criteria, then you'll get on the waiting list. If not, then we'll have to do some other things, like determine if there are extrahepatic metastases or not. If it's in the liver, then we can do some liver-directed therapy. We can go to the next slide. Yep, and the next one. So some of the liver-directed therapy, again, looks at whether you're child PA or child PC, and we'll talk about those child Q scores during the discussion about the paper. But here they look at just different factors that can help you determine which therapy would be best useful. You can click the next slide, and the next, and the next. So there's radiofrequency ablation, there's microwave ablation, and the next one, you can use radiotherapy, and the next one, along with embolization. And all of these are usable. It depends on the situation, but and it depends on the institution and what their guidelines are. But yeah. So then after this, we go on to the next slide. Some people look at your Barcelona classification system, the Barcelona Clinic Liver Cancer Staging System, which establishes a prognosis in accordance with 5 stages that are linked to a first-line treatment recommendation. So the expected outcome you see is expressed as median survival. We see 5 years, 2 years, 1 year, according to evidence that's out there. And we note that the liver function should be evaluated beyond the conventional child-Pew or MELD score, because none of them really serves to properly gauge the liver function status. This evaluation should take into consideration certain labs, like the alpha-fetoprotein we're talking about, or CMP. And the preserved liver function, and it includes a group of patients with different degrees of liver function, that liver function reserve has to be carefully evaluated. So for the most part, you can see that people can, let's say, for example, receive chemoembolization and have survival somewhere between 2 and 5 years on a median basis. We can go on to the next slide. Some of the interventional treatments that have come up include ablation, which can be broken down into radiofrequency ablation, which involves local application of radiofrequency thermal energy to the lesion. There's high frequency alternating currents from the tip that burn the surrounding tissue essentially. Then we have microwave ablation, which is similar in that it delivers high frequency microwaves into the tumor tissue. It's been used for hepatic tumor ablation for many years. Another one would be percutaneous ethanol or acetic acid ablation. We can talk about cryoablation, which is somewhat the opposite of microwave in that it uses freeze-thaw cycles to make the tumor susceptible to dying or more resectable. There's embolization, and that's where we use little particles delivered through an artery, specifically the hepatic artery. We can use it blandly without any chemotherapy. You can add chemotherapy to the embolizations, or you can use drug-eluting beads, or we can use radiotherapy. Radioembolization using intraarterial injection of Y90 labeled microspheres, inducing tumor necrosis. It has a pretty good safety profile. Okay, and the next slide. And we can also use embolization in combination with systemic therapy. Here I just wanted to show a quick video of somebody performing. This is Dr. Guimaraes at Medical University of South Carolina. So I want to show, well, there are some indications for it, and typically it's for downstaging the person to make them ready for transplant, keeping the patient within transplant criteria while they're waiting for transplant. Is it playing or it's taking, oh yeah, it's taking time. That's okay, I'll just keep talking while it waits. Some of the labs and imaging that you'll be getting beforehand include the multi-phase contrast enhanced CT or MRI. Here you see him about to perform an intraradial, a transradial embolization. So at most institutions, the patient's imaging will be viewed by a multidisciplinary tumor board with collaborative effort between IR and oncology and hepatobiliary transplant surgery in order to devise the best treatment plan for each of your individual patients. And once that decision to treat with transarterial embolotherapy has been made, here's what you'll plan to do. So most TACE will be performed through transfemoral. However, in this case and many other cases, more recently, people are performing through transradial artery approaches. They use the Seldinger approach, which uses access to the artery of choice under ultrasound guidance. You'll use fluoroscopy, a guide wire, and 4 or 5 French curved catheters advance through the vascular sheath to selectively catheterize the celiac artery. And these steps can be made easier by prior review of CT, pre-procedural CT, and MRI, with special attention to any vascular stenoses or any anatomic variants. The celiac and common hepatic arteriograms are performed to delineate downstream anatomy and demonstrate potentially hypervascular tumors. We'll use a catheter and wire that could be advanced through a base catheter into the desired arteries supplying the tumor. Multiple arteriograms in different obliquities are often performed to outline target vessels supplying the tumor. It's like a roadmap to guide you. So, and most of the modern angiographic systems can perform cone beam CT imaging. This creates an intra-procedural CT image during arterial contrast injection, providing precise confirmation of the treatment area and potential for detecting tumors with higher sensitivity than MRI or CT. You'll have your embolic mixture. You see him mixing it up. It'll be slowly injected under continuous or intermittent fluoroscopic guidance until near stasis is confirmed with arteriography. Some physicians add gel foam. It's like a temporary embolic, or they'll add permanent microspheres as administration for the full chemotherapy if the blood flow persists. So all catheters at the end are removed and disposed of in a chemotherapy bin. After this procedure, people can be discharged the day of, or maybe they'll be admitted overnight for observation. Sometimes you have to watch out for post-embolization syndrome, where people just feel bad, vomiting, nausea, malaise. But otherwise, you'll get some labs, check their CMP again, their liver function test, CBCs, follow up with them in a couple weeks, see how they're doing, and that should be it. So thank you. So now, what is this paper talking about? How can we use TACE for hepatocellular carcinoma?
Adlai, fantastic discussion of TACE workup, procedure, Barcelona staging, and the procedure itself. Does anyone have any questions at this point in the journal meeting? Mitchell?
This is kind of just more of a broad question, but if you use a treatment like TACE or just an embolization for hepatocellular carcinoma, will you see tumor markers go down, or would you just assess their status based on complete blood count and other sorts of tests?
It's a great question. I'll direct to the attendings if you guys are on the line.
Absolutely. Yeah, you can see them go down almost immediately.
Yeah, it's pretty beneficial to identify AFP reduction. It gives you some prognostic implications.
Thank you so much.
Awesome question, Mitchell. Does anyone else have any questions or outstanding concerns about hepatocellular carcinoma or TACE procedures?
Say it again.
Oh, I was asking if anyone had any questions. Any questions still?
Yeah.
I have a general question, not specifically for this kind of treatment, but using interventional radiology in cancer settings, would that increase the risk of metastasis, especially if it's metastasized through the blood vessels?
Can you repeat that, please?
just the possibility of having a metastasis induced by the interventional radiology, specifically through like blood vessels in cases like cancer that likes to spread through the blood vessels, like bones or heart or like liver.
I'm not sure I understand the question. However, after we embolize, as soon as you make the tumor ischemic, especially HCC, it reacts by the first couple of days. The angiogenesis and VEGF go sky high, if that's what you're referring to, and the angiogenesis can obviously cause metastases and growth of the tumor, and that's why there's a discussion over whether you partially embolize, in other words, embo-light, where you allow stasis or near stasis versus complete stasis. If you kill the cell, it can't respond in that manner. And there's an argument over should we use complete stasis or near stasis for that.
And if you're referring to the procedure itself causing metastatic disease, I don't think there's any evidence to that.
Thank you so much.
So all right, great question. Go ahead, Ahmed.
Sorry, thank you, Michael. I just had a quick question. So, based on the fact that you're inducing, basically injecting the material so proximal to tumor, is there increased risk of tumor lysis syndrome with this form of treatment?
Yeah, I mean, it depends on the tumor. So we check an LDH in certain, but like certain tumors, you had a lot of necrosis, you have to be cognizant of it. So most of the time, no, we don't see that. We kind of have a limit, but you definitely, anytime you have a rapidly turning over tumor, you check the LDH, you check the K, you'll hydrate them pretty aggressively. So you kind of have an algorithm. You look for the urinary output to kind of minimize those things. But majority of times, no. Certain tumors will lyse more than others, rapid turnover.
Thank you, Dr. Vack and Cherry.
If you, tumor lysis syndrome is rare, but it can occur, and it usually occurs in the larger tumors. And if you have, we like to work on tumors that are 3 centimeters or less, but every once in a while they'll ask us to do something that's 8 centimeters, and you don't go in there and embolize the entire tumor. What you do is you kind of pick it off, maybe at 2 or 3 sessions to reduce the incidence of tumor lysis.
Thank you. Thank you, Dr. Karidi.
All right, excellent questions, everyone. So now we're going to commence the second part of the discussion, which is a specific discussion of a 2010 article, the Precision 5 study that was published in Europe in CVIR. This study relates to specifically what we are putting into the liver when we embolize in TACE. So, what kind of cytotoxic agents are we using? Anyone that doesn't know, can you kind of shout out one of the big cytotoxics that that you might think could be used for this? If you don't know for sure, second year or third year, like what could you use for liver malignancy? I guess the answer is already up there. So doxorubicin is typically used in practice. But the question that this study is trying to address is, how do you deliver the doxorubicin to the liver? Is it suspended in poppy seed oil, lapiodol, a traditionally used agent, or do you try to elute it to beads of a certain diameter? Being the idea with the diameter is that they'd be too large to go through the capillaries and return to systemic circulation. So the idea with elutement to beads is that you actually attach the drug to a compound or molecule that is too big, a substrate, I guess, it's too big to return to systemic circulation, thereby be lodged within the malignancy. So this study aimed to determine if it was actually superior to elute doxorubicin to a bead rather than suspend it in lapiodol. So it's kind of a granular question, but this study will illuminate a lot about TACE and a lot about the way that clinical trials are carried out, specifically in interventional radiology. So a quick overview of what we're going to talk about, background, some of the criteria for inclusion, the methodology. We're going to look at EASL versus EMERCIST staging criteria. We're going to talk about the results of the trial in terms of safety and efficacy. We're going to discuss some of the criteria of the study, which includes intention to treat analysis and the hypothesis of superiority when you're looking at a new treatment. And we're also going to have 2 clinical vignettes. And at the end, hopefully a couple of good questions and some great input from the staff that we have on the line. And at any time, if any of you guys have questions, please interrupt, put it in the chat box. Attendings, if something's wrong or if I'm missing something, please interrupt me, and we'll keep it a good discussion as we go through this. Okay, so I'll ask you a question. If anyone's read this study, and obviously can't hold it against if you haven't, but can anyone kind of describe what the study design might be, if you recall? So the study design was multi-center international prospective single-blind randomized trial. So single-blind because the interventionalists knew what they were mixing, but the patient did not. The study was published in 2009. It was sponsored by Biocompatibles. Biocompatibles is now owned by subsumed by Boston Scientific. So their sole product was this bead to which doxorubicin or a similar anthracycline can be eluted. And now Boston Scientific is selling this product and presumably doing making quite a lot of money off it. So it's always important to think about where the study is coming from. And I think it's significant that this is a sponsored study. It occurred over the course of 3 years and 17 locations across Europe. So what is the clinical question of this study? Can anyone try and summarize what the study was looking at in one sentence, or try and describe it in their own words?
I can give it a go.
Woo!
No, go ahead, please. I insist.
Go for it.
Okay, so essentially using the study population, which was, patients that had unresectable HCC, they were trying to see which intervention was superior between conventional TACE and TACE using the drug-eluting beads with doxorubicin. And by superior, like in safety and efficacy and stuff.
Excellent. Excellent. Well phrased, Carmen. That's exactly how I would put it. Individuals with unresectable HCC, is TACE with drug-eluting beads safer and or more effective than conventional TACE with lapiodol mixed with doxorubicin? So that was what the study was primarily set out to do. And it's important to figure out how they determined that and what kind of metrics were used in terms of operationalizing this question. So this is really where it comes down to the weeds. It's like, if you want to set up a study, how would you do it? I think this is where these journal clubs are very helpful because it forces you to think about these things. So let's look at their inclusion criteria. So they went off the ESAL confirmed diagnosis of HCC. They were looking at patients over the age of 18, which is going to be almost everybody unless you have some genetic predisposition, with intermediate HCC that's unresectable. And they're looking at individuals with Barcelona stage A, B without portal invasion, without extrahepatic spread. So in other words, non-metastatic. In other words, targeting this lesion could actually reduce overall tumor burden for the entire body. So they're looking at ECOG. I assume ECOG is pretty well known, but it's basically your functional status in real life. Like, can you do things by yourself, or are you bed bound, ECOG of 3 or 4? So ECOG of 0 or 1 is like all of us for the most part. And then looking at liver function preserved. So this is a really interesting thing about treating this malignancy, is that it may not actually increase your liver function. It may actually, it could actually decrease your liver function. So the benefit that you get is not by increased liver function. So if you're in gross hepatic encephalopathy, this is not necessarily going to make you better. So the population is pretty specific, but in these individuals where you fit in this criteria, there is actually a benefit to a pretty well proven benefit to receiving this targeted therapy by interventional radiology. And so this is one of the studies that sought to figure out, is there a better way to do this in terms of the standard of care at that time. So who is excluded from this, right? Well, actually, we have a really quick aside here. Carmen, you remember calculating the child Pu on about 200 patients?
Yes, I do.
Yeah. So do you want to talk about a bit about what that entails? Like, what did we put into the calculator? What are the things we're looking at in the lab values?
Okay, so as you can see on the screen here, we would come through these patients' charts and basically go through their labs, put in their bilirubin, their albumin, their INR, and then we would look through the notes and see, based on their physical exam, whether or not they had ascites and whether or not they were encephalopathic. And then you type all that into MedCalc and it'll spit out your answer of, what their score is, 1, 2, 3, or and what class they are. So.
Mm-hmm. And we kept being so surprised that everyone was like CPA or B, and then it was like, of course, because that's like the Barcelona inclusion criteria. Like, there's no CPCs coming through, but I'm sure that it does happen in some cases that someone would be outside of that criteria and given a TACE. But I guess we can talk about the cases that would happen. We can ask Dr. Creedy and Dr. Bordlee if, like, why that would happen or when someone would push for that. That's an interesting question. Who's excluded? Advanced spread, another primary, advanced liver disease. Again, you're going to push people into a worse liver condition than when they started. So you don't want to precipitate liver failure. Previous chemotherapy, previous radiotherapy, or previous TACE. So these are newcomers. And of course, any contraindications receiving doxorubicin. So again, we talked about stratifying the study arms. What does it look like? So you had, these are just the really specifics about how the drug was given. 4 milliliters DC beads, certain size, versus CTACE. So the size is interesting here. It looks like they're using 300 to 500 microns. So the study that Carmen, Dr. Bordlee, Dr. Creedy, and I were looking at was looking at 75 micron doxorubicin alluded to oncozine. So the size is very important, and it's not something that's covered in this study, but it has to do with, I believe, correct me if I'm wrong, the size of the smallest capillaries, insofar as the beads should not be passing through the capillary system or returning to systemic circulation. So I think there's some debate as to what that size is, and also there's a standard variance in terms of the way that the beads are produced, in that some of them may be smaller than stated on the box. So studies have been done since then trying to figure out what the right size of bead to use, but that's just an aside. I think it's a very cool little granular detail that may come up in future practice for all of us. Okay, so what's the primary endpoint of this study? We're looking at 6-month tumor response according to the amended EASL criteria. So what is EASL? So how do you know if you've reached your goal when you are giving someone a treatment? What are you looking at? And in TACE, this is one of the very special. Oh, I have to go back to get my AirPod 1 second. You guys want to?
All right, so what do we? Okay. Come on.
I think I'm back in the system. Can you hear me? Okay, great. So, so this is one of the very cool things, TACE, that can be worked at by radiology. It's one of the few malignancies that can be diagnosed by a radiologist because of the way it uses blood flow. So you look at enhancement on multi-phase CT, both before and after the treatment. So these different criteria, ESAL versus another one that we could use, MRECIST, you're basically looking at the amount of tumor response to the treatment. And your response is stratified into 4 criteria: complete, partial, stable disease versus progressive disease. And these are determined by radiologists. In this study, they used 2 blinded radiologists who would look at the before and after and make a determination with a third radiologist who would arbitrate any kind of disputes between them. So in the way it plays out, I mean, you have people actually reading scans over and over again to figure out what the response was for these people, and they don't see what their treatment is. So ideally, the radiologists are blinded to the actual treatment arm. So you want to make it as non-biased as you can. Here's a little schematic that kind of demonstrates what you're looking at. The white area in that malignancy is enhancement. So modified RECIST and ESAL, you're looking at the reduction in the greatest, for MRECIST, the greatest dimension of enhancing component of that malignancy. So you don't look at the non-enhancing part. You're looking at the part that's basically still alive, I guess, or still malignant. I'm not sure how to describe that, but so for the study that Carmen and Dr. Bordlee and Cree and I were looking at MRECIST. And basically, these are correlated with long-term survival. So you can use tumor response as a proxy for long-term survival. And that's why it's so helpful. You don't have to do the Kaplan-Meier plot necessarily, because this is kind of a stand-in. And that's another thing to think about. So I'm just trying to get us all thinking about the way that we get information in medicine and the nitty-gritty about where it comes from, because I think it's really important to be aware of this as you move forward in practice and have to make decisions and talk to other clinicians about this stuff. So safety endpoint, what are we looking at? We're looking at severe treatment-related adverse events within 30 days. Secondary endpoint, we're looking at liver function parameters, AST, ALT, cardiac function. And why would we look at cardiac function? Can anyone, T2s, M2s, M1s, M2s, tell me why we think about cardiac function in this study?
I think, if I recall correctly, doxorubicin can cause a dilated cardiomyopathy.
Oh my goodness. 10 points for Gryffindor. Yes, as Sketchy reminds us, it's an anthracycline, doxorubicin here. You see the heart's dilated cardiomyopathy. So just tying it back into the one true text, absolutely right, Mitchell. And as we'll see, there is a change. There is a difference between ejection fraction in this study between each treatment group. So the study found that individuals that received conventional TACE actually had worsened ejection fraction. So the idea is perhaps some of that was escaping back to the heart and causing toxicity there. So perhaps the beads remain lodged in the liver, don't cause that issue. We'll return to the fact that what is the best thing at the end of the day, because I'm not sure. I think that's an attending level question that we'll maybe try and ask in a couple slides, like what the actual best thing is between the two. I'm just going to keep on going here. Basically, adverse events are graded, they're standardized. You don't just make them up. Like there's a very common rule book that describes them. And so it's important to be aware when you're doing studies, like what your guidebook for adverse events are. This one used SWOG, which is the Southwestern Oncology Group, but they come off of the CTEAE or whatever this one is. Like it's very standardized. So you're looking at this a lot doing studies. Okay, so what do we find? What did the study show? And it turns out maybe not that exciting. There's some stuff to learn, but the sample size was not that big. You're looking at 201 individuals, roughly 50-50 split, though not completely. There was some attrition. Those individuals were not analyzed in the final statistical analysis. So the study showed that 51% of individuals with drug-eluting TACE showed objective response to treatment as opposed to just 43. However, were these results statistically significant? What do you guys think? No, they were not. I know. So the p-value, so what p-value would we look for a significant finding? Anyone taking step 1 or step 2, feel free to chime in.
0.05.
Yes, yeah, bingo. So that's the thing you look for. And I guarantee you this is on step 2. I have nightmares about it to this day. These questions are gonna show up. Being able to interpret these things and know a significant p-value is gonna help you a lot. So that's the whole point of this journal club, is to get comfortable thinking about this stuff. And it's helped me a lot as well, just making this stuff. So no, the results were not significant. However, when you do run these sort of red cap things through like statistical software, you can just do descriptive stats, which will show you like things that maybe you wouldn't have set out. So it's not your primary objective to learn something, but you can make associations that don't test the original hypothesis, but are interesting for future studies. So this is kind of where we learn things in medicine, is like, oh, this failed to reject the null hypothesis. But there were 2 or 3 really interesting things that came out of this study that inform clinical care moving forward. And one of those is that drug-eluting beads are actually more effective in people with more advanced disease. In other words, people with worse liver function, worse day-to-day function, or multiple lesions or recurrent disease. So the study did find that. They found that in roughly 2/3 of these patients, the objective response and disease control rates were significantly higher, with a p-value less than 0.05. There were also some really notable safety descriptive findings. First of all, there was no significant difference between the two. So p-value 0.34, they were equivalent. One was not safer than another in terms of the adverse events within 30 days. However, doing more descriptive statistics, they found that serious liver toxicity and doxorubicin side effects were both significantly lower with drug-eluting beads. And they're looking at AST, ALT, and specifically ejection fraction. So ejection fraction was preserved with the drug-eluting beads, which gets back to the core concept of beads getting lodged in the liver and not returning to systemic circulation, as far as I understand it, why this like operationally is superior. So the bottom line, just to sum everything up, superiority was not demonstrated. However, in patients with more advanced disease, there were descriptive statistics showing that it could be superior. Safety was roughly equivalent. However, follow-up statistics showed that there's a decrease in liver toxicity and doxorubicin side effects with drug-eluting beads. So there were things that came out of this. Okay, so this is really the nitty-gritty here, and I don't know if anyone has a statistics background that can kind of chime in and help with this, but basically what I want to talk about for about 3 or 4 minutes is the sort of rules that govern the way you make a study, to get us thinking about that. So when you have a new treatment, you can't just say this is equivalent to the old treatment, right? You can't just say, oh, let's do this the same way. If you're trying to introduce something new, you want to show that it's a superior product. So that's the way this trial was constructed. You're looking at a hypothesis of superiority. So the null hypothesis then is that the new treatment is not better than the old, not better or the same as. So you want to disprove that. What you're looking at is a delta. Delta is the difference of improvement between the new study and the old study. So if your results are like somewhat better, but not a whole lot better, then you're not going to disprove the null hypothesis. The delta is based on previously understood data given the current standard of care, the gold standard. So one of the reasons why this study didn't reject the null hypothesis was because the assumption for conventional TACE was an efficacy rate of 35%, And in this actual study, in real life, they achieved efficacy of 43.5%. So they actually exceeded what they thought they would for the standard of care. Because they did better than they thought, they couldn't disprove the null hypothesis, and they couldn't show that the new drug was superior. So their delta was not met. So it's really interesting things to think about. Like when you design trials, hopefully, you know, some of us will do that in the future, understanding that it's not just about being the same as or being a little bit better. Like you're looking at a substantial improvement, and you're looking at past performance. And also it's a little bit of like statistical magic how this stuff happens too. And so I'm hoping if anyone has like any background, they can explain this part better. But basically what you're looking at in this trial, to be really specific, they aim to reject with 80% power a one-sided significance with alpha at 0.025. And remember from high school, college stats, alpha is the probability of rejecting the null hypothesis when in fact it is true. So if the p-value is greater than the alpha, you accept the null hypothesis, which in this case it was, and therefore we did not get significant results. So little stats refresher, that was as painful for me as it is for you guys, but I think it's very interesting to dig into that stuff and to be more familiar with it, because they will test it on the boards and you will hate it, but you'll be much more comfortable with it if you get a little bit more familiar and comfortable with it. One last thing I wanted to talk about before we get to discussion questions at the end is intention to treat. And I know this is on the boards. I know this is on NBME 18 or 19, not to spoil it for you guys, but the intention to treat is this idea that everyone who is randomized into their initial arm should be analyzed into their initial arm, regardless of if they followed through with treatment. So if you drop out, if you can't get the treatment, whatever, when you do the analysis, you should still be considered as part of that treatment arm. The idea behind this is that failure happens in clinical practice all the time. And if you account for this through this intention to treat analysis, then you can control for that, basically. Maybe some treatments are more painful. This should control for that. I'm not exactly sure where this came from, but this is like kind of the pinnacle of standard of trials. This trial, you use modified intention to treat. So those that dropped out were not included in the final statistical analysis. But remember this, the bottom line with intention to treat is once randomized, always analyzed. And you will see that on some questions. I know that was on one of the NBMEs, and you'll think of my face when it pops up. So hopefully don't miss that. Okay, so before we get into questions, I'm sure we'll have some good ones before we reach the top of the hour. I have a couple vignettes for you guys. And I'll just quickly read them and see if we'll get some responses. Actually, Carmen, do you want to read this one, or someone from Tulane? Do you guys want to? Andrew, Google said you want to step up and read this?
I can do it. Okay.
All right, hop in, Carmen.
Okay. Okay, so a 58-year-old woman with a history of hepatitis C cirrhosis is referred to an interventional radiologist after 2 lesions were observed on routine liver ultrasound.
I meant one. It was one. It should be one, but proceed.
Okay. CT demonstrated a 3.5 centimeter lobe 5 lesion. Her liver function is child pu B, and her ECOG performance status is 1. According to this study, what is the most appropriate therapy for this patient? A, is it drug-eluted TACE, or is it B, conventional TACE?
All right, anyone want to take a shot?
I can try. Since the person has child pu B, it's considered more advanced. So you would use drug-eluted.
Bingo. That's what the study would suggest. Yeah, that wasn't the primary goal of the study to prove that, but that's what the supplemental stats would suggest. So yeah, I would go with that based on this study. All right, clinical vignette 2.
Hey, real quick.
Yeah.
So, I mean, we know that the liver is divided into segments, right? So it should read a 3.5 centimeter segment 5 lesion, not a lobe 5, okay?
Yeah.
That you would never see anything like to say lobe 5, because that's not, I'm assuming that means segment 5. Okay.
Yeah.
All right.
Overlook.
Gotcha. I will fix that. The next one.
Well, before we move on, any other feedback from the attendings present on kind of this scenario? Any interesting?
Yeah, I mean, my bias would be to go for curative intent in this patient who has a 3.5 centimeter lesion. So if you look at the kind of the level 1 evidence, the RCT data would advocate ablative therapy. The Tenet et al. Article looked at ablative therapy compared to resection, and the 1, 2, and 4 year disease-free and overall survival rate were equivalent. So I think ablative therapy would be kind of the going for curative intent. So I mean, obviously that's not one of the choices here, but just, you know, if I was seeing this patient in the office, that's what I would advocate.
All right, thank you, Dr. V. Thank you, Dr. Bordlee, for catching that one too. Mitchell, you want to take a crack at this one?
Sorry, sure, yeah, absolutely. A 64-year-old man with a history of NASH cirrhosis was considered for TACE after a 3.7 centimeter lesion was identified on CT. He meets inclusion criteria for a new clinical trial and is randomized into the CTACE group. On the day of TACE, he has a severe reaction to anesthetic and the procedure is aborted before doxorubicin luperidol can be administered. According to intention to treat analysis, what is the most appropriate use of this patient's data? A, he should be analyzed in the CTACE group. B, he should be analyzed in the DE TACE group. Or C, he should not be included in data analysis. Just based on what we talked about with intention to treat, since he was randomized in the CTACE, he should stay in CTACE, right?
Bingo. That's the point I'm trying to drive home, as counterintuitive as that seems, but that's the core concept of intention to treat. All right, great work, guys. A couple of final questions. I'm not sure how relevant any of these are. We talked about the weaknesses. I guess if anyone has any questions about the construction of clinical trials, but I kind of want to talk about more about TACE and liver-directed therapy. Any questions about TACE, as Dr. V said, versus ablation versus Y90? I'm kind of want to pull the room and see if anyone has any questions and see if the attendings have any input. And Austin, actually, if you have any specific questions that you can think of to get people going, I'm not sure how good these are, but trying to generate some discussion points here.
Yeah, I think this question about where therapy is moving is great. Like TACE versus ablation versus Y90. Something I'm pretty curious about myself. So yeah, I would appreciate any input.
Same, yeah.
Yeah, I don't know.
I don't know if Bordlee or Curry, do you want to speak up? But, you know, kind of my approach in the office is I look at, you know, so from an HCC standpoint, first of all, the diagnosis, right? So it's cirrhotics, Hep B, they're the ones who are going to get it. And it's based on OPTN criteria, Organ Procurement Transplant Network, or it's kind of an equivalent is what's called LIRADS, liver RADS, LIRADS. And basically the diagnosis is based on advanced imaging, multi-phase CT, 4-phase CT, or dynamic MR. And what these tumors will do, they'll be bright on the arterial phase scan, which is about 20 seconds after the injection of contrast. And they'll wash out in the portal venous or delayed phase, which is anywhere between 60 to 80 seconds to up to 2 minutes. So once it's a centimeter, it's an HCC, okay? So arterial enhancement portal venous washout. We don't need to biopsy them. It's diagnostic. The reason why we don't biopsy is twofold. One is bleeding risk and potential seeding risk. The seeding risk was kind of quoted by Lovett at about 12% in the kind of the original data in a non-coaxial fashion. So that's why kind of the diagnosis, right? Cirrhotic Hep B with a hypervascular mass, arterial enhancement portal venous washout. So that's number one, we diagnose it. Then we look for where this thing likes to go. Like, is it in one lobe of the liver or both lobes of the liver? Or is it invaded the vessel, meaning macrovascular invasion? Or is it extrahepatic, meaning it's in regional lymph nodes, or it's the places it likes to go is lung, adrenal gland, bone. Okay, that's where it tends to go. So we're looking at those spots to see if it's extrahepatic. So now we know it's at like kind of what the tumor extent is, the TNM kind of extent of the tumor. If it's in the liver, then we, transplant's ideal, especially in a sicker liver, like a child's C or patient with ascites or, bilirubin that's elevated with a high INR and low albumin, meaning they're synthetically declined. So that patient would likely benefit most from a transplant because you not only take care of the cancer, but also the bad liver, right? There's not much we can do about a bad liver except, potentially reduce the progression. So we can palliate a bad liver, but we can't really do anything to replace it. We don't have dialysis for the liver. So that's kind of the way I look at kind of from a liver standpoint. So I break it down, and I'd be curious to see what the others do. I break it down synthetic functional liver and portal hypertension. So synthetic functional liver I feel is most important, which is T-bili, INR, and albumin. So it's kind of the ALB score and kind of a combo of that. But then the portal hypertension, I mostly look at platelets. If the spleen is big and the platelets are low, that suggests to me this patient has high pressure in the liver backing things up. So that's kind of the way I break that down. So now I have how bad is the liver, right? How bad is a tumor? And then I look at the other things like, is the heart okay? Is ejection fraction okay? Do they have aortic valvular disease? Do they have prior myocardial issues like infarctions, et cetera, CAD? And then how bad is the lungs? If they, most of the times they have decent lungs, but as long as, COPD. So heart, lung, liver, and then kidney, what's their GFR? So now I've kind of stratified their physiologic status, and then you want functional status. Like how frail is this patient? ECOG is a way to stratify it, like how active they are. Are they able to do their ADLs? Are they able to do their work? Are they able to do tasks? So you get an idea of how functional that individual is, So now you have how bad is the liver, how bad the physiologic status of the patient, how bad the tumor is, and now you can decide what you want to do. And there's so many options, right? So again, transplant is kind of curative intent, and the likelihood of a new tumor popping up is like less than 10% by 10 years in a properly selected patient. So not every patient can get transplanted, right? And that's why they've developed the kind of Milan criteria, which is like 1 less than 5 or 3 less than 3, because that subset based on the Massafera data suggests that those patients do well. Now there is a extended criteria, which is the UCSF criteria, which is a little bit more than that, but that's the gist of it. Is most people use Milan worldwide. So anything beyond that, they may not do as well because they're on immunosuppressive therapy, et cetera. So now you have kind of transplant criteria. All right. Ablative therapy, I'm curious to see what the others do, but roughly 3 to 5 centimeters based on the two kind of prospective RCTs that we have. All right. So that's ablative therapy. And then, surgical resection, again, you have to have a pretty good liver because you can't take out too much liver you need about 40% future liver remnant in a kind of child's a cirrhotic. So it tells you you can only take out so much liver. The transplant resection, ablative therapy, and then the local regional therapies, the transarterial therapies, TACE, TACE, Y90 are all kind of transarterial therapies. And, we don't have a lot of head-to-head comparisons. We have some like this. And then Karen Brown's article where she compared TACE to bland embolization and so on and so forth. So we don't have a ton of head-to-head, but these are the important to figure out which one of these is best from a transarterial standpoint. And then systemics are getting better. We only had one agent, sorafenib, based on 2 trials, Asia Pacific trial and the SHARP trial. And that showed prolonged improvement of survival about 2 to 3 months. So it took someone from 8 months of survival to around roughly 11. But then they started to get other agents like lenvatinib, which was another first-line agent that was equivalent to sorafenib. And they've even gotten to a newer agent, atezolizumab and Avastin, which is showing over 13.5 months survival. So arguably that'll be the new first-line agent. So we're starting to see a paradigm shift. And then there's second-line agents that you can use. So that's the amalgam of therapies that we can offer these patients. And it's based on that kind of algorithmic approach and what the patient desires, right? Patient may say, I don't want a transplant. I don't want to go under the knife. And that's the patient preference, or I don't want chemo or I don't want the side effects. So all those have to go into the decision-making when you see them in the office. I'd be curious to see Dr. Bordlee and Dr. Caridi have, how they approach it.
Very well spoken. We share a lot of the same methods. Just to simplify it, if the patient has a single lesion or 2 lesions, and we can get to it via ablation, we are always looking for ablation from a curative standpoint. Obviously, if the lesions are bigger, we sometimes do what's called TACE and ablate. We do a TACE and then we ablate the next day for lesions greater than 3 centimeters. You know, and then those lesions that are difficult to get to percutaneously, we'll typically do TACE. Not TACE. Deb TACE, sorry. Using the beads. And then also bland embolization is also, you know, a viable solution for some patients as well. So it really just depends location of the tumor, other comorbidities of the patient, the liver function of the patient, and that's basically a quick, just a quick summary of what we do. Jim, you have anything to add to that?
I don't really have anything to add other than what I think both of you are saying is, and what most people do nowadays. When this first started, it was more of a shotgun kind of approach. You know, you would taste these patients once a month for 3 months, and then now what's the most important thing to do is to tailor the treatment to the patient's exam, just like we heard, and tailor to the patient's disease, and that's how you get your best results. Every patient has to be treated as an individual, and you go through all of those variables that we just heard, and you pick out the best one for that patient.
Yeah, and then what's your kind of, I mean, my follow-up algorithm is basically depending on their tumor burden, but minimum every 3 months for 2 years. If they have stable disease, then I'll progress every 6 months for life, or if they get a transplant, and then, you know, pretty much otherwise every 3 months roughly, with kind of liver labs and imaging. So usually I'll get at least 1 chest CT at some point, and then typically just for staging purposes, then I'll usually get either liver MR or CT multi-phase. Curious what others do. Hello?
Typically for us, we have hepatology does a lot of the management of the patients. They do ask occasionally for our recommendations, but the management of the patient is largely in the hepatologist's hands.
I did have a question for the attendings, and something that I don't know if there's a lot of data on, but looking at, but obviously a huge cost differential is looking at TACE versus Y90 ablation. I was wondering if Dr. Creedy, just like offering your impression, kind of what do you see moving forward, being the more dominant intra-arterial method for addressing liver malignancy? What's your impression between the two, besides cost?
Okay, and it kind of falls back on what I was just saying. That I think sometimes we have cults in medicine, and people choose what cult they're in, and then they use that product. Again, we look at every patient. We've been tending to do more and more Y90 because of segmentectomy, lobectomy, and some of the specifics from Y90. But again, we're going to tailor it to the patient and their disease. But we have been doing more Y90 than previously. And
I had a question. Sometimes I hear about the pain profile being different in those who get radioembolization versus gland embolization or chemoembolization. Is that found to be in your practice? You know.
What's the question?
Well, the people who receive radioembolization, do they have less incidence of pain after the procedure than those who get ethanol ablation or chemoembolization? Does it make sense? Does that question not make sense?
No,
yeah,
that
no,
makes,
I mean,
makes sense. I,
Okay.
go ahead.
I'm a little biased on stuff. I don't think there's a difference, especially if we found that we hydrate the patients and treat them, and we send our patients home after 4 hours. And I know the Y90 people talk about doing the same thing. I'm talking about the people who only do Y90. And so we don't see a lot of complications or especially pain. But I have to tell you, which I want as medical students, I want you to learn that, a lot of times you'll go to a lecture and we have our gurus up there lecturing on how to do things and their results. Well, it's different for the person who does one a month and out in the community. Okay, and I have my own medical problem, and I got to spend a weekend with a bunch of Y90 patients, and I heard things that you would never hear at a national meeting by the gurus who are some of them happen to be my friends. And I approached them and I said, when you talk about this in public, you have to mention, some of the things that maybe you don't see, but can occur, and I think that's important to keep in mind. One of the lectures I give is don't be a dabbler. You're either going to be serious about doing this, but don't dabble, because then you can have problems. And a few of the patients that had Y90 did have abdominal pain and did have some problems that we don't typically hear about, and I think you just have to pay attention to that.
Yeah, and I think that's why, in my opinion, kind of prospective clinical trials are of best benefit to kind of glean that data. We always think we do better than we really do. And so once you prospectively study it in a core lab adjudicated fashion, kind of independent observers, in as least bias as possible, that's where you get data, right? So I would look at kind of SARA and Cervinib and Surflox and Foxar Global to get some of the true adverse events in a kind of a prospective trial acquisition. And then you can get some adverse events. So one of the things I was surprised by is the mild suppression that was seen as an adverse event in SARA and Cervinib when you compare it to systemic therapies. So again, I strongly encourage you to kind of look at that. So we really don't know until you do a head-to-head comparison, right, in a randomized fashion, to know what works and what doesn't. And so really to answer these questions, we need a TACE versus Y90 in a certain subset, right? You have to standardize the protocols and go, hey, and is this one better than the other? And then once you do that, then that potentially becomes a new gold standard. Then you take it against another agent, right? So if you look at the chemo trials, that's what they did, right? They look at sorafenib, and that's their new gold standard because sorafenib has a survival benefit. So let's compare lenvatinib. Let's compare atezolizumab and see what our survival curves are. All right, and so we have to do the same thing when it comes to interventional therapies. We're very good at kind of innovating, but we need to validate better. And so we need to learn from our interventional cardiology and cardiology colleagues and how they design trials and really focus on that. And so instead of retrospective analysis, we need more prospective data gathering.
If I told you that you could probably get the same survival using bland embo as you can with Y90, most of you would think that I'm joking. But you can do that. So there's two things that we look at when we're evaluating a patient. One of them is survival, which is hard to prove. And I'm not so sure that a good response means more survival than somebody who has less of a response. I don't know if that's been proven. Maybe you can help with that and answer that question. But the other thing is quality of life. Like if I see a patient and I know I got to bring that patient back, several times as opposed to one time, and I'm going to choose the quality of life over something it's more involved and may not be the best for the patient, even though the survival is the same.
Yeah, and that's two great points. So again, it's always patient wishes, but one of the surrogates is progression-free survival or time to progression, and that doesn't necessarily correlate with overall survival. So kind of the gold standard for how long is, patients are going to want to know how long do I have, and they also want to know when do I need to get my stuff in order, these things. And these are reality. When you see them in the office, you're going to have to tell them these things. They're going to expect that for you to be honest with them. So you got to know natural history of disease. And so also it's not just quantity of time, it's quality of time. So if you're getting, and a lot of my patients that, you know, we studied our own experience with sorafenib, and a lot of them just were miserable. Most of them couldn't tolerate full dose, and they had a lot of systemic toxicity. So you're not getting a lot of reduction in tumor burden, but they did improve survival, right? So, but they were just not happy. They were not happy a lot of the time. They had anorexia, they had hand-foot syndrome. They just didn't feel good. So patients may not want that 2-3 months. And a lot of mine didn't want those 2-3 months because they're like, I don't want to be miserable for whatever time I have. So again, this is where my primary role is in my office is being a guidance counselor. So you accrue all this clinical knowledge and your experience of following patients and seeing, you know, when they suffer, you suffer with them. You feel bad. You're like, the last thing you want to do as a physician is cause harm. And sometimes we do, right? And we make them worse than our intended cause. And when you realize that is in the office, when you see them and their family. And that's an important lesson. So I think that's why I think the clinic is so invaluable to follow these patients, to see what works and what doesn't, but also what they've gone through, you know? And if they don't, you know, for example, if you're doing a patient with pleural fusion, you're doing thoras on them, fine. But if you have to do a TOC pleurodesis, they're in the hospital for a week and maybe they have a total of 3 months left. Well, that week in the hospital is not what they want. So they want to be home with their loved ones. So always think about that. It's not just quantity of time, but it's quality of time. And as Dr. Caridi was saying, you know, you have to consider all these things. Making a tumor go away doesn't necessarily mean that you're improving their survival or improving the quality of life.
Our sorafenib study that we did at UF, one of the first studies, 45% of the patients dropped out because of the side effects.
Yeah, so yeah, I mean, that's again another reason why we need more kind of data to support our decision making. Because what I need is information or evidence to guide my decision making. Like, what should I use? You know, it's kind of a hodgepodge. It's like dealer's choice. But I want to know, like, is yttrium 90 better in this patient than drug-eluting beads or TACE? And it's a lot of theory, but where's the evidence? Where's my quality evidence, right? From this trial, it's 6 months. I'm not going to get a survival benefit data, right? It would have been nice if they extended it for 2-3 years and showed, is there a survival difference? That would have been helpful for me, right? But a 6-month primary endpoint with no long-term follow-up doesn't give you those answers. And when you start doing subset analysis separate from the primary endpoint, when that wasn't really initially in the inclusion kind of decision-making, it's an interesting thing, but you really need to study that separately. So always look at that as well. Like, what was the primary intent of the trial? You know, and I know we reviewed the ATTRACT trial. That was a well-designed, you know, whatever the endpoint was and whatever the outcome was, it was a well-designed randomized trial, in my opinion. Core lab adjudicated, had a good primary endpoint, et cetera. Now, maybe we need to do a second trial looking for iliofemoral and whatnot, but recruitment is a challenge, right? And we as interventionalists need to do a much better job in being aggressive about recruiting and seeing them in the office and going, hey, you need to be in a clinical trial, take out our bias of this or that, and just tell the patient, you know, we really don't know. We don't know what the equipoise is. But if you're a Y90 person, you're going to push Y90 even with an unconscious bias towards that, as opposed to saying, yeah, you should do this. So that's another danger that we have as, you know, healthcare professionals, in being biased based on our own thought process. You want to take that out. We need to be scientists when it comes to evaluating this.
Thank you so much for your input to all the attendings here. Does anyone else have any further questions while we, you know, have all these great minds present?
Well, speaking of Dr. Curdy, I love your carbon dioxide work, and some of the stuff that you post in the cases are amazing. And so I encourage you to look at, I know you have a website with a lot of information, I think, on the NCBH, and some of the stuff is pretty cool, and some of the cases that he has and the information, but I think we could do a lot more with CO2 throughout, below the diaphragm and various areas. And so I encourage you to look at some of the work he's done. It's pretty awe-inspiring and pretty exciting.
I had a quick question, since we've been talking about adverse events. Something I read in the article that I thought was interesting was how with the drug-eluting beads, which is kind of what Michael talked about. I mean, the whole purpose is to keep the medicine in the tumor. But it was talking about how you are seeing lower systemic levels of the doxorubicin. Is that something that you're seeing translate clinically, like patients feel better compared to conventional TACE, or is that more of like a theoretical idea?
Well, I think the patients have less side effects. The drug is ionically bound to the bead. And I think that decreases the severity of side effects from the drug going systemically, because I don't think there's as much systemic spread or systemic distribution.
Yeah, I mean, it's a great question. In theory, you're right. And the interesting thing is, if you look at the dosing, they did 150 milligrams. They used which is, I don't know what, I'm curious to see what Bruce and Dr. Curdy are utilizing. It's a bit on the higher end, one. Two is the main adverse event that they noticed, if you look with the greater than 10% change, was hair loss. So, and I wouldn't underestimate the impact of hair loss on patients, but it was the main toxicity that had greater than 10% change. Right.
And also remember in the study that this is they didn't get real selective. This was given low bar. The drug and Piodyl emulsion was given in a low bar fashion and then backed up with gel foam. Typically with the drug-eluting beads, you can get very selective nowadays, especially with microcatheters, and probably use less than they used in the study. So that also helps with side effects.
So yeah, that's a great point. Technique is really important. So super selective catheterization will minimize your kind of liver toxicity and your potentially adverse events. So I think that, when you're doing this, you should strongly, you should consider that, as because that's what we do. We target therapy. We try to be precise. So I think that's a great point.
All right. I think unless anyone else has any further questions, we can wrap this up. And if Dr. Dr. Bordlee, and Dr. Creedy are willing to stick around, if anyone else has any further questions. But thank you so much for joining, and I hope you learned a lot. We'll be hosting another one in November with NYIT as well as New York. So tune in for that. Thank you, everyone.
Thank you, everyone.
Thank you so much, everybody.
Thank you very much.